In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Now, look at extract 1, questions 31 to 36. You hear an interview with a physician called Dr. Matthew Leach, who's talking about meningitis. You now have 90 seconds to read questions 31 to 36.
Hello everyone, I'm here with Dr. Matthew Leach, an expert on infectious disease who's going to tell us about meningitis. Thank you for being with us today, Dr. Leach. Can you tell me more about the disease?
Sure. Well, first off, not everyone who is exposed actually develops meningitis, but there are some common symptoms to look out for in those that are at risk. It can be quite difficult for patients to realise they have meningitis in the early stages, as the symptoms can lead them to believe that they are developing the flu. They'll simply feel tired and achy for a few days. As this infection develops, patients may then notice a sudden onset of fever, headache, and in particular, neck stiffness. Other possible symptoms include nausea or vomiting, confusion, sensitivity to light, no appetite or thirst, or even a skin rash. If left untreated, bacterial meningitis is very dangerous, quickly progressing to seizures, shock, and even death.
Wow, that sounds pretty serious. And you mentioned that certain people may be at risk. Now, which people are more likely to develop meningitis?
Well, there are many causes of meningitis, but one of the most severe is caused by the bacteria Neisseria meningitidis. The bacteria are spread by respiratory droplets and are often seen in college students. This is largely because of the sudden change in their lifestyle. College students, particularly those who live on campus, are exposed to a hotbed of different infections they haven't previously encountered. All these kids from different parts of the US and the rest of the world get together, live in small dorms with each other, go to parties. All that close contact really is a breeding ground for infection.
Okay. Well, that makes sense. Now, can you tell us about a specific patient who had this type of meningitis?
Of course. I treated an 18-year-old man in his first year of college who was living in the dormitories. There was a flu going round, and he started to feel the same symptoms. He was working hard to try to complete a couple of important essays before the deadline, and he planned to delay going to the doctors until he had submitted them. Soon after the initial symptoms, however, his roommate found him in severe pain and feverish and brought him to the emergency department where we diagnosed meningitis. We took a sample of spinal fluid but started him on antibiotics before we got the results back.
So you mentioned that you started antibiotics before you got the spinal fluid test results back. Can you tell me why?
Right. As I mentioned, there are many causes of meningitis, like viruses, funguses, parasites, and bacteria. However, it can take some time to determine the exact cause, and waiting for the answer without treatment will make the patient worse. Instead, we use the patient's presentation, age, and our determination of the most likely cause to start antibiotics that would kill many of the causes. Once we get the results back on the cause, we can change the antibiotics to be more specific. By doing this, we don't delay treatment and are able to reduce the chance of complications.
Right, I see. So, how is your patient doing now after being treated? Will he experience any long-term after effects?
Well, he is currently doing much better. He responded well to antibiotic treatment and regained his mental state within a few days. Unless the patient has a disease of his immune system, meningitis is unlikely to recur. Because this patient had some delay before seeking treatment, he may still have some side effects, but it will take some time to see what long-term effect it will have on him. Bacterial meningitis requires urgent medical treatment and can cause serious complications such as hearing loss, memory difficulty, brain damage, gait problems, or kidney failure.
Well, let's hope he makes a full recovery. And aside from seeking immediate medical treatment, what advice can you give to our listeners today about bacterial meningitis?
So, first off, there is a vaccine that is effective at preventing this disease. So anyone in close contact with a large group of people, such as those living in a military base or on a college campus, should ask their doctor about it. Finally, if you have not had the shot and have spent a lot of time with someone who is later diagnosed with meningitis, wear a mask to prevent spreading the bacteria and go and see a doctor immediately. There are medications that can reduce your risk of developing meningitis, and getting treated immediately will reduce your risk significantly.
Now, turn over and look at Extract 2, questions 37 to 42. You hear a clinical psychiatrist called Dr. Evelina Horton discuss treatment for agitated patients in an emergency setting. You now have 90 seconds to read questions 37 to 42.
Hello everyone, my name is Dr. Evelina Horton, and in my presentation today I'd like to discuss an issue that I deal with daily, de-escalating agitated patients in an emergency setting. To provide some perspective on the issue, most patients who enter the hospital do so via the emergency department, ED. Many won't have received medical treatment yet, and that can make it more likely for these patients to become agitated. This can be exacerbated by their medical condition, a psychiatric illness or other stress factors. Given the chaotic and crowded nature of the ED, it's imperative that we identify agitated patients early and apply non-physical de-escalation techniques as soon as possible. The provider who is going to initiate the de-escalation process should make sure that they create a considerable amount of space between themselves and the patient, and make sure that no one else is closer to the patient than they are. This not only gives the patient space, but also keeps the provider safe in the event of attempted physical violence. Ideally, both the patient and provider should also be able to leave the area without the other blocking their exit. Body language and tone of voice convey overall emotional state to a patient, so providers should remain outwardly calm throughout the encounter. When speaking to the patient, you should start by introducing your name and role in the team. You should determine how the patient prefers to be addressed, and err on the side of being respectful. Use short sentences and simple vocabulary to enhance understanding. Leave a suitable amount of time between statements to allow patients to process what is being said. Sometimes repetition and enunciation may be necessary. Eye contact should be intermittent, so the patient does not think you're staring, and verbal responses should be calm without any hint of insults or challenges. Only one provider should interact with the patient, as multiple speakers can confuse an agitated patient. When the patient speaks, it's important to identify what their wants and feelings are, even if they may be impossible to address at this time. Try to consider things from the patient's perspective. Although they may be suffering under a particular delusion, such as paranoia, try to understand how the patient might feel or react if that delusion happened to be true. While we do not want to endorse these delusions, it's important to find common ground. For instance, if the patient is agitated because they think they are being followed, the provider can agree with the general principle, saying something like, "I understand that your suspicion of other people can make it hard to get the treatment you need here." It is also okay for a provider to agree that while they may not be having the same experience as a patient with an obvious delusion, they can believe the patient is having that experience and reacting to it. In addition, patients should be encouraged to make choices in order to give them a sense of control over the current situation and diffuse their overall aggressiveness. These choices should be realistic, however, and deliverable, as unfulfilled promises may backfire and irreparably damage the therapeutic alliance. Some of these choices can include medications to help calm the patient. A good way to state this is, it's important for you to stay calm so we can talk. Can we provide you with some medication to help you feel less anxious? Offering patients a choice between different medications or routes of delivery may also provide a feeling of control to the patient. Lastly, when the crisis is over, a key technique is debriefing both the patients and staff on how the situation went. The patient, now calm, may be able to provide more insights on what they were thinking and how they were feeling at the time. The provider can discuss coping skills or alternative options in order to prevent another aggressive incident in the future. It is also important to talk to staff as well, to gain any third-party feedback on the provider-patient interaction, what was appropriate, what helped de-escalate the patient, and any other changes that could be made to ensure patient, staff, and bystander safety. These techniques can be applicable to a wide variety of patients in numerous settings. They're not just restricted to the emergency department. Our hope is that providers will be able to de-escalate patients safely and effectively without having to resort to the use of physical or chemical restraints, which should be considered only when all other approaches have failed.